Welcome to EHJ today, here at ESC 2015 in London. My name is Stefan Agewall, Professor of Cardiology in Oslo, Norway, and also Editor-in-Chief of European Heart Journal Cardiovascular Pharmacotherapy. I'm joined here by Professor Martin Cowie, and we are going to discuss a work presented here at the Congress entitled Treatment of Sleep Disordered Breathing with Predominant Central Sleep Apnea with Adaptive Servo Ventilation in Patients with Chronic Heart Failure. So Martin, what's the background for doing such a study?
Well, we've known for many years that patients with heart failure are at risk of developing central sleep apnea. We've had Cheyne-Stokes respiration. Every medical student's talked about it. Now, we know that they have a worse prognosis if they develop it. And we had some small studies to suggest that if you treated the central sleep apnea by ventilation-type therapy overnight, you could improve ventricular function, you could improve biomarkers, improve quality of life. So there was beginning to be a move for physicians to treat and to look for central sleep apnea. We thought it was very important to actually test that hypothesis in a robust randomized trial. So this is the world's largest trial of sleep apnea, happens to be in systolic heart failure patients, but there have been very few randomized trials of the treatment of sleep apnea. And we all thought it would be positive. Abnormal physiology, worse prognosis, get rid of it, patients will do better. And that's why we do randomized trials, because we were taken completely by surprise, both cardiologists and respiratory physicians. Overall, the study was neutral. That was all-cause mortality, life-saving intervention, and worsening heart failure. But if you looked at cardiovascular mortality, there was a 34% increase, which was statistically highly significant. And even total mortality was also statistically significantly higher. We had about 400 deaths in the trial. We followed up 1,300 or so patients for 4 years. So a game changer. This therapy actually seems to be hazardous to systolic heart failure patients. So I think it's a very important trial. It's changed practice, and it's also raised the question of, do we really understand central sleep apnea? Is it compensatory? Is it harmful? Should we be treating? What should we be doing? So there's lots of questions.
Do you have any ideas why this happened?
Well, that took us completely by surprise. So we then went back to the drawing board, and actually, interestingly, a guy called Norton had published an editorial about 2 or 3 years ago, just putting up the idea, maybe Cheyne-Stokes isn't so bad after all, and here's 4 reasons why it might be beneficial for a heart failure patient. And to be honest, most people thought, that's ridiculous. Cheyne-Stokes, worse prognosis, it's got to be harmful. But now, of course, we're revisiting that editorial and going back to the physiology from the 60s and the 70s. And there's several reasons why Cheyne-Stokes might actually be good for a heart failure patient. It rests the respiratory muscles cyclically, so it maintains their strength, prevents alkalosis, which can be harmful, of course, in terms of ventricular arrhythmia. It may also reset the autonomic nervous system. And because you're ventilating and hyperventilating, it actually increases your lung volume and gives you a kind of intrinsic positive airway pressure and increased oxygenation at times. So maybe it's compensatory. The other possible explanation, and we've just published a paper in the New England Journal of Medicine, and there's an editorial which also picks up on this. So the other explanation is it's nothing to do about Cheyne-Stokes. It's about positive airway pressure may be harmful on a poor left ventricle and somehow might change the hemodynamics. Personally, I'm less in favour of that because we use positive airway pressure on heart failure patients. There's been other trials in other settings, doesn't seem to be harm. And also looking at our data, the increased mortality seems to be sudden deaths during the day as well as at night, and not progressive pump failure deaths or progressive pump failure hospitalizations.
And what about different subgroups? Was the tendency the same in all kind of patients?
Yes, we looked at a huge number of subgroups, and there were only 2 subgroups that showed anything. And bearing in mind, of course, there's multiple testing going on here, but there are 2 clear things. For total mortality, the percentage of Cheyne-Stokes respiration was strongly associated with the harm of the intervention. So the more Cheyne-Stokes you had in your breathing pattern, the worse the intervention seemed to be, which kind of goes along with the line that Cheyne-Stokes might be compensatory, don't get rid of it.
So total unexpectedly?
unexpectedly. And the only other subgroup was for cardiovascular mortality, where the harm seemed to be largely focused in those with the lowest ejection fractions in our study, so below 30%. There seemed to be a signal that the cardiovascular harm was mostly in those patients. So one other subgroup I should mention, which is interesting, because we recruited from expert centres and they were all in very good treatment, about 55% of our patients had an implanted device, ICD or CRTD. So we got data for arrhythmia for some of those patients, and we saw that those that had a device were partially protected from the increase in cardiovascular mortality, which would also suggest it's an arrhythmic thing by getting rid of chain stokes. Only partially protected. They were still a signal for harm, but it was less than those that didn't have a device. So I think it's a really important study for physicians to tell them what not to do, and for us to go back and try and understand the physiology better.
So this is obviously the end of such treatment for patients with heart failure, but a lot of other patients have this kind of treatment. Should they throw away the equipment now, or how can you implicate these results to the whole population?
Well, I think we have to be really careful that we don't extrapolate from this physiology. This was systolic heart failure only. We didn't have any preserved ejection fractions. It was actually quite severe systolic heart failure with chain Stokes respiration and treated by ASV type of ventilation. So that we know is harmful. I don't think we can extrapolate to preserved ejection fraction heart failure, which is a very different syndrome, and certainly we shouldn't extrapolate to obstructive sleep apnea, which is by far and away the most common type of sleep apnea, diabetic, hypertensive, obese patients, their upper airway collapses. That's a totally different physiology from central sleep apnea, where it's the lack of respiratory drive and the cyclical variation in respiration, and the airway's got nothing to do with it. So I think we have to be really careful physicians don't get confused. Our study was in central sleep apnea in systolic heart failure. I don't think you can extrapolate to obstructive sleep apnea, nor even to preserved ejection fraction heart failure.
But I would guess that we will get a lot of phone calls from patients using this kind of treatment, and your message to them is to continue as?
No, my message is not to continue. If they have heart failure and they're on ASV therapy, what I've said to my patients...
If not heart failure in the background?
Yeah, well, just to be absolutely clear, if they've got heart failure and ASV, I tell them that the trial has now been done, we know that there's no benefit for them and there might be harm, so I'd like them to stop the therapy. And patients are quite willing to accept that. To be honest, in many countries, very few physicians were using ASV therapy, but there are some countries where tens of thousands of patients were on it already, so that's a big job to stop them. But coming back to your original question about obstructive sleep apnea and CPAP therapy, we don't have any evidence that there's harm from that in patients. Physiology is very abnormal, big pressure swings, the patients are sleepy during the day, there can be a danger if they're driving. I think it's really important that we don't suddenly change therapy for that group of patients. So once again, it's a very different group of patients. I can't really tell you what you should do there. I think you should continue with the current guidelines. But for systolic heart failure and central sleep apnea, don't treat the central sleep apnea.
Right. So what will happen now? What's your next step, next study? What should we do?
Well, I'm very keen, as are all investigators, to try and look at this mechanism of increased cardiovascular mortality. Is it sudden death? What type of sudden death? What are the risk factors for that? What's the physiology? So there's a whole piece of work on that. We also have a major sub-study that we'll be publishing subsequently with detailed MRI studies, neurohormones, etc., quality of life, cognitive function. So we have a very clear idea of what actually happens to these patients with this therapy. So that'll be interesting to put together. I think the sleep apnea world, the respiratory community, are also very interested in the results. This is the first large randomized trial of any form of sleep apnea therapy. So it's opened up lots of questions for lots of physicians, both respiratory and cardiac, about the physiology, about the most appropriate therapy, about the phenotype, about what kind of intervention should be done and when, what is the evidence base. So I think this will rejuvenate the whole area and force it to come up with really firm evidence-based guidelines.
Right. So, Martin, what's your take-home message to the listeners?
I've got several take-home messages. One, we still need to do randomized trials, because however neat your physiology and your hypothesis, you can be proven wrong. So it's good to do trials. Secondly, just because it doesn't give you what you expect, don't be disappointed. It can make a real change to practice. And the clinical take-home message is, if you happen to have been used ASV to treat systolic heart failure associated central sleep apnea, you really do need to think about the potential benefits and harms for the individual patient. I wouldn't advise doing it. But the whole area of sleep apnea, fascinating physiology. We need a lot more research and a lot more communication between respiratory physicians and cardiologists so that we work together to try and understand what's going on.
Thank you. And thank you for watching us.